Good evening, friends. I am from the Believers Church Medical College Hospital. My faculty and I came across two very exciting articles recently, which to us, we thought that this would be relevant at a time when the world is looking for answers for newer treatments. There was one which came out in the European Medical Journal of Hepatology on PLEX in liver cell failure, and a more recent one last month in the Current Medical Issues on low volume plasma exchange and low dose steroids. We wondered whether this would be the answer that the world is seeking for the treatment of COVID-19. And so we searched literature, and then I decided to speak to the authors. And I have with me Dr. C.E. Eapen, who is currently the head of gastrointestinal sciences at the Christian Medical College, Vellore, and Dr. Uday Zachariah, the current head of the Department of Hepatology at the Christian Medical College of Vellore. And as we spoke, I realized that Dr. Eapen has been on this journey for the last 16 years, started out while he was on study leave in Birmingham, and was given the Sheila Sherlock Fellowship Award by the European Association for the Study of the Liver Diseases. And what started there as a study on microangiopathy has now grown over the years with possible treatments for acute liver cell failure, treatment for rat poisoning, those who are suffering because of that, and a whole lot of other possibilities. And we now know that this could be something that would be the answer for the treatment if started at the right time for the right patients with COVID-19. Therefore, I am here with Dr. Eapen and Dr. Uday. Thank you so much for accepting my request to explain this to me and my colleagues. We look forward to listening to your talk. Please explain what this new modality of treatment is. What should we be thinking about? What is the way forward?
Plasma exchange to treat acute liver failure is a relatively new concept. However, plasma exchange is established therapy for neurological disorders like Guillain-Barré syndrome or hematology problems like TTP or in nephrology for many decades. While in acute liver failure, this is an exciting new treatment option available. Now, first I would like to clarify and discuss a few of the terminologies. Plasma exchange is often confused with convalescent plasma therapy, especially it's in the news now for treatment of COVID. Plasma exchange can also be shortened as using terminology of TPE, meaning therapeutic plasma exchange, or PEX, or we like calling it PLEX. So what is plasma exchange? Plasma exchange is composed of two components: plasmapheresis, where plasma is removed from the body of the patient and replaced with a fluid. For liver failure patients, we prefer the fluid for replacement as fresh frozen plasma. So plasmapheresis in combination with replacement with fresh frozen plasma is plasma exchange. In the adult, there are 5 liters of blood volume, half of which is cells and the other half is plasma. So thereby in the adult, 2.5 liters is plasma. So plasma exchange, to contrast with convalescent plasma therapy, as I mentioned, plasma exchange is a combination of plasmapheresis as well as replacement with FFP in patients with liver failure. In contrast, passive antibody therapy, commonly used as immunoglobulins, for example, to prevent tetanus, or convalescent plasma therapy is another form of passive antibody therapy, wherein plasma from a person who recovered from a viral infection is taken and infused to treat another patient with the same virus infection. So First, let me move on now to introduction to plasma exchange or PLEX in liver failure. At CMC Vellore, the extracorporeal therapy for hepatic indications in liver diseases started off in 2002, where we used albumin dialysis with Mars. However, that was not so popular. It did not seem to translate into survival benefit. In contrast, plasma exchange has become a popular form of therapy here. We are encouraged by the improving results and survival in patients with acute liver failure syndromes, and to date we have done this therapy for 175 patients in the past few years. The only randomized controlled trial of plasma exchange was conducted in 3 European countries. In this trial, patients were given 8 to 12 liters of plasma exchange per day, on an average of 10 liters per day, and they were randomized into either getting standard medical therapy versus high volume plasma exchange for 3 days. This study found that in the patients who did not undergo liver transplantation, there was a 10% increase in survival in those patients randomized to obtain high volume plasma exchange. At CMC, we now use PLEX to treat liver diseases for the following indications: for patients with acute liver injury or acute liver failure or acute or chronic liver failure. And the commonest etiologies are rat killer poison, is common in southern India, seronegative or idiosyncratic drug-induced hepatitis, and alcohol-related A-ACLF or alcoholic hepatitis. So I'll focus on our outcomes with rat killer-induced hepatotoxicity. Case series reported from Amrita Institute in Kochi a few years ago described very severe criteria of severe liver injury, indicating the need for liver transplantation in this form of liver injury. Now, of those patients who met these criteria, which were derived from that data set, there were 22 such patients at that institute. 14 patients underwent liver transplantation, and the survival was 79%. Of 8 patients who did not undergo liver transplantation, who met these criteria, none survived, who received only standard medical therapy. At CMC, there were 10 patients who met these criteria. None of the families opted for liver transplantation. With plasma exchange, there was a 50% survival in this group. When we look at all the patients with rat killer hepatotoxicity in our department from December 2017 to date and divide them into numbers of 15, in the last 15 patients, in fact, only one patient died, and that patient, there was some technical problem by which PLEX did not happen. So increasingly, it looks like with this new therapy with plasma exchange, patients are surviving without need for liver transplantation. Now, how does PLEX work? I will cover these topics. There is data suggesting that the microcirculation in the liver is affected in acute liver failure, and PLEX seems to improve this. So I will start with the interaction between von Willebrand factor and platelets. VWF is common knowledge to the MBBS student, as the deficiency of VWF leads to the commonest inherited bleeding disorder called von Willebrand disease. This is a hemophilia-like illness, and the patient presents with a bleeding diastasis. However, the interest in liver disease is the opposite. Here it is raised VWF levels. So if we took the logic that for many decades, different forms of renal replacement therapy have been tried in patients with acute liver failure, but there was no improvement in survival. While if PLEX is starting to improve survival in acute liver failure, the answer may be that some molecules which are too large to be dialyzed could explain how the survival benefit is occurring with plasma exchange. So von Willebrand factor comes out as different multimers, and as you can see, they are much larger than what can be removed by dialysis. Studies from different parts of the world show that raised VWF levels in outpatients with cirrhosis to the tune of 2 to 3-fold elevation predicts death over a 24 to 33 month time period, and this is as good as MELD score for a predictor of survival. Data from our department show that in patients with acute and chronic liver failure, the VWF levels are 7-fold high and predicted death over an 8-day time period. And in patients with acute liver injury and acute liver failure, they were 4 to 4.5-fold high and predicted death over a 7-day time period. And again, it was as good as MELD score in predicting survival. Now let me move on to another topic which is related. In dengue infections, we recognize there is acute onset thrombocytopenia. Where do the platelets disappear in this acute illness? So here there is a cartoon from the movie Finding Nemo, where outside the Sydney Harbour, the ocean is full of fish. In fact, if you take a sample of blood from when you do a peripheral blood sampling, there are more number of cells per cubic millimeter than shown in this picture. For example, the red blood cells are in millions per cubic millimeter and platelets are in lakhs per cubic millimeter. So in this movie, when the shark comes, all these fish go and hide somewhere. In inflammatory milieu like dengue, cells like platelets go and hide or sequester onto the endothelium. So now when we take a peripheral blood sample, we find there is thrombocytopenia. When the inflammatory milieu moves away, these platelets probably start come back into the free-flowing circulation, and now you find the platelet counts are normalized. In this movie, there are these corals which are finger-shaped projections. This is how von Willebrand factor molecules look like, protein look like. These are expressed and secreted from the endothelium. They are very adhesive or sticky, and the platelets come and stick onto these. In cartoons depicting these, suppose this is an arteriole supplying a vital organ of the body, and here are the endothelial cells which are expressing the ultra large von Willebrand factor. Normally these are cleaved by this enzyme, this protease called ADAMTase13. In acute inflammation, there is increased levels of VWF as well as decreased ADAMTase13 levels, which leads to platelet microthrombi. And such platelet microthrombi can now occlude the microcirculation in these vital organs. So transfusing isolated platelets into this patient with dengue and thrombocytopenia due to endothelial sequestration runs a risk of worsening microthrombi, reducing microcirculatory perfusion further, and precipitating vital organ failure and death. So using that logic, one could postulate that acute liver failure appears to be like a traffic jam. Really, the problem is a problem of the flow of traffic in the road in front of the hospital in this picture, and one can make out the large molecules like VWF, the inflammatory cells, and the other blood cells, the blood stream, which are now getting jammed up here. There's a blockage happening, as well as macrophages lining the side of the road, which when activated will contribute further to the traffic jam. Now, the same road, couple of hours later, has less traffic, and one finds that the liver failure could have reversed or resolved. I move now on to innate immune response and macrophage activated syndrome and hemophagocytosis, yet another phenomenon in acute liver failure. The immune system of our body is divided into innate and adaptive responses systems. The innate immune response has to react within 20 to 30 minutes of identifying the enemy. Usually these are microbes, bacteria. In contrast, the adaptive T and B cell response takes days to weeks time. So this rapid response of the innate immune system is by many mechanisms. And one such mechanism is for the innate immune cells to literally eat the enemy. So the cells of the innate immune system are termed phagocytes, or cells which eat. And in this cartoon, one can make out, it's very evident who is the macrophage. So Obelix is the chap who eats, while neutrophils, like Asterix, spray cytokines onto the invading bacteria and then eat them up. Here is the picture of a neutrophil literally eating an anthrax bacillus. Now, if this innate immune response becomes uncontrolled macrophage activation can be triggered by microbes, dead or damaged cells, or xenobiotics, that is foreign material, then the macrophage responds by the eating response and keeps on phagocytosing, while the neutrophil will keep on producing cytokines, a cytokine storm, increasing or hyperinflammation, multi-organ failure, and death is possible. So the activated macrophages not getting turned off is recognized in macrophage activation syndrome, also known as hemophagocytic lymphohistiocytosis or HLH, and can be fatal. Here is a picture of Epstein-Barr virus in a child triggering HLH, and the histiocyte in the bone marrow has phagocytosed, has eaten up an RBC as well as platelets in this picture. In a series of 50 patients we had studied with alcoholic A-ACLF, we recognized that different markers of macrophage activation when studied, for example, ferritin more than 500 was there in 82%, while CD163, a specific marker for macrophage activation, was there in 100% of patients. This marker, CD163, was 9-fold elevated in these study patients compared to healthy controls. And these scores positively correlated with the liver disease severity scores. So I'm reiterating that point about the traffic jam in the microcirculation, a block in the sludging of microcirculation as a cause of acute liver failure due to endothelial activation, which secretes large molecules like VWF, causing sludging of the lumen of the microcirculation. Macrophages lining the road, which when they enlarge will further narrow the lumen of the road, as well as an influx of inflammatory cells, which will again contribute to sludging. Now, the protocol for treating using plasma exchange to treat liver failure, we use a low volume plasma exchange. We have been using 50% of plasma volume, so usually it's 1 to 1.5 liters daily for 3 days, and it's important to give a combination of low dose steroids along with this. We use prednisolone tablets at 10 milligrams per day, started a day prior to PLEX and continued for 1 to 4 weeks later. Now, we have presented the data on 3 patients who had dengue and multi-organ failure, who had secondary HLH, acute liver failure and multi-organ failure, who were treated with this protocol of low volume PLEX and low dose steroids. So the patients clearly had markers of macrophage activation, endothelial activation, and multi-organ failure. And the 2 patients who did not require mechanical ventilation survived, while the 1 patient who was ventilated did not survive. Now, it is possible that this treatment may benefit patients with severe COVID. So that is a postulate we have proposed in this article, which has come out in Current Medical Issues. The parallel being that In severe COVID, the vital organ being involved is lung, while in acute liver failure, it is the liver. Secondary HLH is recognized in severe COVID. The poor prognostic factors in severe COVID include rising plasma D-dimer levels, high ferritin, a marker of macrophage activation, or HLH. So we have proposed that low volume PLEX and low dose steroids needs to be studied in severe COVID patients with acute lung injury who have evidence of endothelial and macrophage activation, or either then, and rising D-dimer levels. The window of the narrow therapeutic window of when these patients would benefit from this treatment needs to be decided, and this particular treatment could show a way out in patients, in those select group of patients who are hypoxemic with acute lung injury in severe COVID. I would like to acknowledge the guidance for this decade-long research by Professor Elvin Elliott from the Liver Unit at Birmingham and Dr. Ian Mackey from UCL London, who helped us set up these assays at Vellore. Thank you.
Dr. Eapen, thank you so much for that excellent presentation. I must say my colleagues and I believe that this is the way forward. But could you just explain that hypothesis once again so that it can be a little clearer for us?
So as you rightly said, it remains a hypothesis, but the similarities are striking. In the liver failure patient, the vital organ being affected is the liver. In COVID-19, the vital organ is the lung. And the picture of the traffic jam suggests that the blockage to or sludging of the microcirculation in the liver is what could be the predominant factor causing acute liver failure, and sludging of the microcirculation, the lung capillaries, could be the major factor contributing to hypoxemia. So, again the similarities are endothelial and macrophage activation are well documented in both diseases and correlate with disease progression and death. So the similarities of underlying mechanism of disease are similar. We have been encouraged by the increasing survival with plasma exchange in patients with acute liver failure and acute liver injury. As we showed you, the numbers of patients who are undergoing this treatment now has crossed 175 now.